The hematological system includes blood, blood cells, lymph, and organs involved with blood formation or blood storage. A basic knowledge of hematology is useful in clinical settings to evaluate the patient's ability to transport oxygen and carbon dioxide, coagulate blood, and combat infections. Assessment of the hematological system is based on the patient's health history, physical examination, and results of diagnostic studies. Blood cell production, better known as hematopoiesis, occurs within the bone marrow. Bone marrow is a soft material that fills the central core of bones. Although there are two types of bone marrow, yellow and red, it is the red marrow that actively produces blood cells. In the adult, the red marrow is found primarily in the flat and irregular bones, such as the ends of long bones, pelvic bones, vertebrae, sacrum, sternum, ribs, flat cranial bones, and scapula. All three types of blood cells, RBCs, WBCs, and platelets, develop from a common hemopoietic stem cell within the bone marrow. The hemopoietic stem cell is best described as a non-differentiated immature blood cell found in the bone marrow. As the cells mature and differentiate, several types of blood cells are formed. The marrow is able to respond to increased demands for various types of blood cells by increasing production via a negative feedback system. The bone marrow is stimulated by various factors that cause differentiation of the stem cell into one of the committed hemopoietic cells. Blood is a type of connective tissue that performs three major functions: transportation, regulation, and protection. The blood is responsible to transport oxygen, nutrients, hormones, and waste products around the body. Blood also plays a role in the regulation of fluid, electrolyte, and acid-base balance. Finally, the blood has a protective role in its ability to clot and combat infections. There are two major components to blood: plasma and blood cells. Approximately 55% of blood is plasma. Plasma is composed primarily of water, but it also contains proteins, electrolytes, gases, nutrients, and waste. About 45% of blood is composed of formed elements or blood cells. There are three types of blood cells: erythrocytes, leukocytes, and thrombocytes. The primary function of erythrocytes include transport of gases, both oxygen and carbon dioxide, and assistance in maintaining acid-base balance. The composition and features of an erythrocyte are ideal for its gas transportation role. It is a flexible cell with a unique biconcave shape. Flexibility enables the cell to alter its shape so that it can easily pass through tiny capillaries. The cell membrane is very thin to facilitate the diffusion of gases. Erythrocytes are primarily composed of a large molecule called hemoglobin. Hemoglobin, a complex protein iron compound composed of heme, an iron compound, and globin, a simple protein, functions to bind with oxygen and carbon dioxide. As erythrocytes circulate through the capillaries surrounding alveoli within the lung, oxygen attaches to the iron on the hemoglobin. The oxygen-bound hemoglobin is referred to oxyhemoglobin and is responsible for giving arterial blood its bright red appearance. As RBCs flow to body tissues, oxygen detaches from the hemoglobin and diffuses from the capillary into tissue cells. Carbon dioxide diffuses from the tissue cells into the capillaries, attaches to the globin portion of the hemoglobin, and is transported to the lungs for removal. Hemoglobin also acts as a buffer and plays a role in maintaining acid-base balance. Erythropoiesis, the process of RBC production, is regulated by cellular oxygen requirements and general metabolic activity. Erythropoiesis is stimulated by hypoxia and controlled by erythropoietin, a glycoprotein growth factor synthesized and released by the kidney. Erythropoietin stimulates the bone marrow to increase erythrocyte production. Erythropoiesis is also influenced by the availability of nutrients. Many essential nutrients are necessary for erythropoiesis, including protein, iron, folate, cobalamin, riboflavin, and pyroxidine. Erythrocyte production is also affected by endocrine hormones such as thyroxine, corticosteroids, and testosterone. Several distinct cell types evolve during erythrocyte maturation. The reticulocyte is an immature erythrocyte. The reticulocyte count measures the rate at which new RBCs appear in circulation. Reticulocytes can develop into mature RBCs within 48 hours of release into circulation. Therefore, assessing the number of reticulocytes is a useful means of evaluating the rate and adequacy of erythrocyte production. Hemolysis, destruction of RBCs by monocytes and macrophages, removes abnormal, defective, damaged, and old RBCs from circulation. Hemolysis of RBCs results in increased bilirubin to be processed by the body. When hemolysis occurs via normal mechanism, the liver is able to conjugate and excrete bilirubin that is released. The normal lifespan of an erythrocyte is 120 days. Leukocytes appear white when separated from blood. Like RBCs, leukocytes originate from stem cells within the bone marrow. There are 5 different types of leukocytes, each of which has a different function. Leukocytes contain granules within the cytoplasm are called granulocytes. Granulocytes include 3 types: neutrophils, basophils, and eosinophils. Leukocytes that do not have granules within the cytoplasm are called agranulocytes and include lymphocytes and monocytes. The primary function of granulocytes is phagocytosis, a process by which WBCs ingest or engulf any unwanted organism and then digest and kill it. The neutrophil is the most common type of granulocyte, accounting for 50% to 70% of all WBCs. Neutrophils are the primary phagocytic cell involved in acute inflammatory responses. A mature neutrophil is called a segmented neutrophil, or SEG, because the nucleus is segmented into 2 to 5 lobes connected by strands. An immature neutrophil is called a band. Although band cells are sometimes found in peripheral circulation of normal persons and are capable of phagocytosis, the mature neutrophil is much more effective. Eosinophils account for only 2% to 4% of all WBCs. They have a similar but reduced ability for phagocytosis. One of their major functions is to engulf antigen-antibody complexes formed during an allergic response. They also are able to defend against parasitic infections. Basophils make up less than 2% of all leukocytes. They have a limited role in phagocytosis. These cells have a cytoplasmic granules that contain heparin, serotonin, and histamine. If a basophil is stimulated by an antigen or by tissue injury, it will respond by releasing substances within the granules. This is part of the response seen in allergic and inflammatory reactions. Lymphocytes, one of the agranular leukocytes, constitutes 20% to 40% of WBCs. The main function of lymphocytes is related to the immune response. Lymphocytes form the basics of the cellular and humoral immune responses. 2 lymphocyte subtypes are B cells and T cells. Although T cells precursors originate in bone marrow, these cells migrate to the thymus gland, for further differentiation into T cells. Monocytes are the other type of agranular leukocyte. These cells account for approximately 4% to 8% of the total WBCs. Monocytes are potent phagocytic cells. They can ingest small or large masses of matter such as bacteria, dead cells, tissue debris, and old or defective RBCs. Monocytes are the second type of WBCs to arrive at the scene of an injury. These cells are only present in the blood for a very short time before they migrate into tissues and become macrophages. In addition to macrophages that have differentiated from monocytes, resident macrophages can be found in tissues. These resident macrophages are given special names. For example, Kupffer cells in the liver, osteoclasts in the bone, alveolar macrophages in the lung. These macrophages protect the body from pathogens at the entry points and are more phagocytic than monocytes. Macrophages also interact with lymphocytes to facilitate humoral and cellular immune responses. We will be discussing more about lymphocytes and macrophages during our exploration of the immune system. The primary function of thrombocytes or platelets is to initiate the clotting process by producing an initial platelet plug in the early phases of the clotting process. Platelets must be available in sufficient numbers and must be structurally and metabolically sound for blood clotting to occur. Platelets maintain capillary integrity by working as plugs to close any openings in the capillary wall. At the site of any capillary damage, platelet activation is initiated. Increasing number of platelets accumulate to form an initial plug that is stabilized with clotting factors. Platelets are also important in the process of clot shrinkage and retraction. Platelets, like other blood cells, originate from stem cells within the bone marrow. The stem cells undergoes differentiation by transforming into a megakaryocyte, which is the production of platelets. Platelet production is partially regulated by thrombopoietin, a growth factor acting on the bone marrow to stimulate platelet production. Typically, platelets have a lifespan of only 5 to 10 days. I need to also include that leukocytes, or WBCs, have a lifespan that can be up to a few hours to sometimes years. And that is what helps us with our immune response when we're faced with an attack of organisms that are unknown to our body, which we'll talk further about in our discussions of the immune system. Iron is obtained from food and dietary supplements. Approximately 1 milligram of every 10 to 20 milligrams of iron ingested is absorbed in the small intestines, most specifically the duodenum and the upper jejunum. Therefore, only 5% to 10% of ingested iron is absorbed. Iron is present in all RBCs as heme in hemoglobin and in a stored form. The heme in hemoglobin accounts for 2/3 of the body's iron. The other 1/3 of iron is stored as ferritin in the bone marrow, spleen, liver, and in macrophages. When the stored iron is not replaced, hemoglobin production is reduced. Transferrin, which is synthesized in the liver, serves as a carrier for plasma protein for iron. The degree to which transferrin is saturated with iron is a reliable indicator of the iron supply for the developing red blood cells. As part of normal iron metabolism, iron is recycled after macrophages in the liver and spleen phagocytize, or ingest and destroy old and damaged red blood cells. Iron binds to transferrin in the plasma or is stored as ferritin. Homeostasis is a term used to describe the blood clotting process. This process is important to minimize blood loss when various body structures are injured. Four components contribute to normal homeostasis: vascular response, platelet plug formation, the development of the fibrin clot on platelet plug by plasma clotting factors, and the ultimate lysis of the clot. When a blood vessel is injured, an immediate vasoconstrictive response occurs. Vasoconstriction reduces leakage of blood from the vessel, not only by restricting the vessel size, but also by pressing the endothelial surfaces together. The later reaction enhances vessel wall stickiness and maintains closure of the vessel even after the vasoconstriction subsides. Platelets stick to one another and form clumps. The stickiness is termed adhesiveness, and the formation of clumps is termed agglutination. In addition to their independent contribution to clotting, platelets also facilitate the reaction of plasma clotting factors. The formation of a visible fibrin clot on the platelet plug is the conclusion of a complex series of reactions involving different clotting factors. The plasma clotting factors are labeled with both names and Roman numerals. Plasma proteins circulate in inactive forms until stimulated to initiate clotting through one of two pathways, intrinsic or extrinsic. The intrinsic pathway is activated by collagen exposure from endothelial injury when blood vessel is damaged. The extrinsic pathway is initiated when tissue factor or tissue thromboblastin is released extravascularly from injured tissues. Regardless of whether clotting is initiated by substances internal or external to the blood vessel, coagulation ultimately follows the same final common pathway of the clotting cascade. Thrombin, in the common pathway, is the most powerful enzyme in the coagulation process. It converts fibrinogen to fibrin, which is an essential component of a blood clot. Just as some elements foster coagulation, others interfere with clotting. They are anticoagulants. This counter mechanism to blood clotting serves to keep blood in its fluid state. Anticoagulation may be achieved by two means: antithrombins and fibrinolysis. As the name implies, antithrombins keep blood in a fluid state by antagonizing thrombin, a powerful coagulant. Heparin is an example of an anticoagulant. The second means of maintaining blood in the fluid state is fibrinolysis, a process resulting in the dissolution of the fibrin clot. The fibrinolytic system is initiated when plasminogen is activated to plasmin. Thrombin is one of the substances that can activate the conversion of plasminogen to plasmin, thereby promoting fibrinolysis. If fibrinolysis is excessive, the patient will be predisposed to bleeding. Another component of the hematologic system is the spleen, which is located in the upper left quadrant of the abdomen. The function of the spleen can be classified into four major functions: hemopoietic, filtration, immunologic, and storage. Hemopoietic function is manifested by the spleen's ability to produce RBCs during fetal development. The filtration function is demonstrated by the spleen's ability to remove old and defective RBCs from circulation by phagocytosis. Filtration also involves the reuse of iron. The spleen is able to catabolize hemoglobin released by hemolysis and return the iron component of hemoglobin to the bone marrow for reuse. The spleen also plays an important role in filtering circulating bacteria. The immunologic function is demonstrated by the spleen's rich supply of lymphocytes, monocytes, and stored immunoglobulins. The storage function is reflected in its role as a storage site for RBCs and platelets. Approximately 30% of the platelet mass is stored in the spleen. The lymph system, consisting of lymph fluid, lymphatic capillaries, ducts, and lymph nodes, carries fluid from the interstitial spaces to the blood. It is by means of the lymph that proteins and fat from the GI tract and certain hormones are able to return to the circulatory system. The lymph system also returns excess interstitial fluid to the blood, which is important in preventing the development of edema. Lymph fluid is pale yellow interstitial fluid that has diffused through lymphatic capillary walls. It circulates through a special vasculature much as blood moves through the blood vessels. The formation of lymph fluid increases when interstitial fluid increases, thereby forcing more fluid into the lymph system. The lymphatic capillaries are thin-walled vessels that have an irregular diameter. They are somewhat larger than blood capillaries and do not contain valves. Lymphatic capillaries unite to form lymphatic vessels, also called lymphatic channels, that carry all lymph fluid to either the right lymphatic duct or the thoracic duct. These large lymphatic ducts drain into the subclavian veins in the neck. The lymph nodes are also a part of the lymphatic system. Structurally, the nodes are small clumps of lymphatic tissue and are found in groups along lymph vessels at various sites. There are over 200 lymph nodes throughout the body, with the greatest predominance being in the abdomen surrounding the GI tract. A primary function of lymph nodes is filtration of pathogens and foreign particles that are carried by lymph to the nodes. The liver functions as a filter. It also produces all the precoagulants that are essential to homeostasis and blood coagulation. Additionally, it stores iron that is in excess of tissue needs. Hepcidin, produced by the liver, is a key regulator of iron balance. The synthesis of hepcidin is stimulated by iron overload or inflammation. Physiologic aging is a gradual process that involves cell loss and organ atrophy. The amount of red marrow and the number of stem cells decrease with aging. The remaining stem cells maintain their functional capacity to divide, but they decrease in number because they are gradually replaced by non-functional fat cells. Although the older adult is still capable of maintaining adequate blood cell levels, the reserve capacity leaves the older adult more vulnerable to possible problems with clotting, oxygen transport, and fighting infection, especially during periods of increased demand. This results in diminished ability of an older adult to compensate for an acute or chronic illness. Iron absorption is not impaired in the older patient, but adequate nutrition intake of iron may be decreased. It is essential to assess for signs of disease processes such as GI bleeding before concluding the decreased hemoglobin level are caused solely by aging. The osmotic fragility of RBCs is increased in older persons. This may account for a slight increase in mean corpuscular volume, MCV, and a slight decrease in mean corpuscular hemoglobin concentration, MCHC, of erythrocytes in some older individuals. The total WBC count and differential are generally not affected by aging. Leukocyte function is also well preserved. However, during an infection, the older adult may have only a minimal elevation in the total WBC count. These laboratory findings suggest a diminished bone marrow reserve of granulocytes in older adults and reflect the impaired stimulation of hemopoiesis. Platelets are unaffected by the aging process. However, changes in vascular integrity from aging can manifest as easy bruising. The effects of aging on the hematologic studies are listed on this slide. Age and gender are important to consider when assessing the patient's hematologic status. Bone marrow function and immune activity decrease with age. Liver function, the presence of known immunologic or hematologic disorders, current drug use, dietary patterns, socioeconomic status are important to hematologic assessment. Because the liver makes clotting factors, ask about manifestations that may indicate liver problems, such as jaundice, anemia, and gallstones. Previous radiation therapy for cancer may impair hematologic function if marrow-forming bones were in the radiation path. Ask about the patient's occupation, hobbies, and the location of housing. This information may identify exposure to agents that affect bone marrow and hematologic function. Check all drugs the patient has used in the past 3 weeks, especially antibiotics, because these drugs can lead to clotting problems or bone marrow depression. Ask the patient about use of blood thinners and NSAIDs, which change blood clotting activity. Diet can alter cell quality and affect blood clotting. Use this information to determine the causes of anemias and of protein, mineral, or vitamin deficiencies. Diets high in fat and carbohydrates and low in protein, iron, and vitamins can cause many types of anemias and decrease the function of all blood cells. Ask about alcohol consumption because chronic alcoholism causes nutritional deficiencies and impairs the liver, both of which reduce blood clotting. Certain dietary habits can enhance blood clotting. Diets high in vitamin K, found in leafy green vegetables, may increase the rate of blood clotting. Assess the amount of salads and other raw vegetables that the patient eats and whether supplemental vitamins and calcium are used. Ask about personal resources, such as finances and social support. A person with poor income may have a diet low in iron and protein because most food sources of these substances are often more expensive. An accurate family history is important because many disorders affecting blood and blood clotting are inherited. Assess the whole body because blood problems may reduce oxygen delivery and tissue perfusion to all systems. Inspect the skin and mucous membranes for pallor or jaundice. Assess nail beds for pallor or cyanosis. Inspect for petechiae, which are pinpoint hemorrhagic lesions, and large bruises, also called ecchymosis. Check the skin for turgor and ask about itching, because dry skin or itching can indicate hematologic disease. Assess body hair distribution patterns, because this could be an indication of poor circulation. Check for pallor or ulcerations of the mouth mucosa. The tongue may be completely smooth in pernicious and iron deficiency anemias, or smooth and beefy red in nutritional deficiencies. Inspect and palpate all lymph node areas. Document any lymph node enlargement, including whether palpation of the enlarged node causes pain and whether the enlarged node moves or remains fixed with palpation. When blood problems reduce oxygen delivery, the lungs work harder to make adjustments that can maintain tissue perfusion. Assess the rate and depth of respirations while the patient is at rest, as well as during after mild physical activity. Have the patient walk 20 steps in 10 seconds. Assess whether the patient is fatigued easily, has SOB or shortness of breath at rest or on exertion, or needs extra pillows to breathe well at night. Anemia can cause these symptoms as a result of respiratory changes made as adjustments to reduce tissue oxygen levels. When blood problems reduce oxygen delivery, the heart works harder to make adjustments to maintain tissue perfusion. Pulses may become weak and thready. Observe for distended neck veins, edema, or signs of phlebitis. Listen for murmurs, gallops, irregular rhythms, and abnormal blood pressure. Systolic blood pressure tends to be lower than normal when the patient has excessive erythrocytes. Severe anemia can cause heart enlargement and heart disease as the heart tries to compensate for reduced oxygen delivery. The kidneys have many blood vessels, and bleeding problems may cause gross or occult hematuria, which is blood in the urine. Inspect urine for color. Hematuria may appear grossly bloody red or dark brownish golden yellow. Urine. Test the urine for proteins because blood contains protein, and blood in urine increases in protein content. Rib or sternal tenderness may occur with leukemia, cancer of the blood, when bone marrow greatly overproduces cells, increasing pressure in the bones. The adult spleen is usually not palpable. An enlarged spleen, however, occurs with many hematologic problems. The spleen lies under the ribs on the left side. When enlarged, the spleen can be identified by its movement during respiration. Have the patient lie in a relaxed, supine position while you stand on the patient's right and palpate the left upper quadrant. Palpating the edge of the liver in the right upper quadrant of the abdomen can detect hepatic enlargement, which often occurs with hematologic problems. Examination of cranial nerves and testing neurologic function are important in hematologic assessment because some problems cause specific changes. The patient with hematologic problems may have a chronic illness or an acute episode of a chronic illness. In either case, each person brings his or her own coping style to the illness. Develop a rapport with the patient and learn what coping mechanisms he or she has successfully used in the past. Ask the patient and family members about social support networks and financial resources. A problem in these areas can interfere with patients' adherence to therapy. The most direct means of evaluating the hematologic system is through laboratory analysis and other diagnostic tests. The complete blood count, CBC, involves several laboratory tests, each of which serves to assess the three major blood cells formed in the bone marrow. The platelet count is the number of platelets per microliter of blood. Normal platelet counts are between 150,000 and 400,000. A more extensive listing of clotting studies are included on this slide. The laboratory tests used in evaluating iron metabolism are listed on this slide, as well as additional tests for nutritional deficiencies resulting in anemias. Bone marrow aspiration or biopsy, which are similar invasive procedures, are performed to evaluate the patient's hematologic status when other tests show persistent abnormal findings that indicate a possible problem in blood cell production or maturation. Results provide information about bone marrow function, including the production of all blood cells and platelets. In a bone marrow aspiration, cells and fluid are suctioned from the bone marrow. In a bone marrow biopsy, solid tissue and cells are obtained by coring out an area of bone marrow with a large bore needle. Standard X-rays may be used to diagnose some hematologic problems. For example, multiple myeloma causes a classic bone destruction with a Swiss cheese appearance on X-ray. Assessment of the patient with a suspected hematologic problem can include radioisotope imaging. Isotopes are used to evaluate the bone marrow for sites of active blood cell formation and sites of iron storage.